All right, let's talk about the pharmacology of drugs that we use to manage diabetes. And I'm sure you are very familiar with most of these drugs, so hopefully I can shed a little light on exactly how they work. And this also, I know I say it every time, but big part of patient education. Okay, so as always, before we talk about the drugs, I want to talk a little bit about the disease mechanism so that then we can fit in how the drugs works, right? So let's take a few minutes to look at the pathophysiology of diabetes, which is really fairly complex. So your slide says that diabetes is a disease that occurs when there is either an absolute or relative deficiency of the hormone that catalyzes fuel storage, and that hormone is insulin. Insulin is an endocrine problem, and endocrine problems are about hormones, typically either not enough or too much. Diabetes is a little bit more complicated in that when we talk about not enough insulin, we either can have absolutely none, which is type 1 diabetes, an absolute absence of insulin, or a relative deficiency, which means there is insulin on board, but not enough to do the job that it needs to do. This can either be further complicated by the fact that in some patients, the amount of insulin actually has the actual amount, the quantification of insulin has nothing to do with what's wrong. It's that the insulin can't work. There are other abnormal physiologic mechanisms that render insulin ineffective. And so the patient actually has high levels of insulin or supraphysiologic levels of insulin. If you just did an insulin level, you would find it to be very high. But because it can't work right, the body thinks that there is a deficiency of insulin, and this is also referred to as a relative deficiency. So in diabetes, we will talk about the fact that there is either no insulin or there is not enough to do the job. But in the case of not enough to do the job, that could mean that insulin is present but low. It could mean that it is present in normal levels but can't do the job, or it could mean that it's present in elevated levels but still can't do the job. The disease is characterized by elevated plasma glucose and a hemoglobin A1C. So plasma glucose, when you measure somebody's plasma glucose, whether it's, by a venipuncture and a tube that's sent to the lab that reports like a basic metabolic panel and there's a glucose in it, or whether you do a finger stick glucose, when you do a glucose, you are just getting whatever snapshot in time, whatever that patient's sugar was just that minute. And that can be influenced by so many things. It's useful in the short term and the immediate, but it's so easily influenced. Sugar can really fluctuate through the day depending on the medications that the patient takes, their activity, their disease state, etc. So a plasma glucose is a snapshot in time. The hemoglobin A1C is a lab test that gives us, it reports it in a percentage. The hemoglobin A1C might be reported as 5%, 6%, 7%, 8%, etc. And what the A1C is a snapshot of what the patient's estimated average plasma glucose has been over the preceding 3 to 4 months. So the hemoglobin A1C is not variable based on how much insulin the patient took today, or if they took their meds today, or if they've been sick for the last 24 hours. That won't affect the hemoglobin A1C. The hemoglobin A1C gives you a vision, it gives you a view of what the average estimated glucose has been over the last several months. So it's an entirely different measure. This is what we use in the outpatient world to evaluate, number one, a diagnosis of diabetes, and then to evaluate glucose control. So if somebody's taking their meds the way they should, and they come in today and their sugar's a little high, say 180 or 190, we would think, wow, that's high. But then if you look at their hemoglobin A1C, it might be 6%, which means, which is fine. It's at goal. It's not something you would have to change meds for. So it just gives you a different perspective, and we use them both together. Okay, so talking about insulin, a few words about insulin here. It is popularly recognized as the hormone that catalyzes glucose uptake. In other words, you know that if the serum glucose is high and you give a patient insulin, the serum glucose will go down. That's because insulin allows cells to take glucose out of serum into the intracellular environment, where it will either be used as a fuel source or it will be converted to some storage form and stored for if the patient needs it later. So although insulin is popularly recognized as the hormone that catalyzes glucose uptake, it is important to remember that it is a complex hormone that also regulates amino acid uptake, protein synthesis, and lipid storage. This is the last I'll really say about it, but just by way of reminder, insulin, yes, we always think about it in terms of blood glucose and insulin, blood sugar and insulin, because insulin does catalyze the uptake of glucose by cells and gets it out of blood. But insulin, its true job as a hormone is that it's an anabolic hormone. It's a hormone of fuel storage. Glucose is one fuel, but proteins and fats are other forms of fuels. So insulin doesn't just put glucose into the cell, it also puts protein into the cell. It breaks it down into its basic parts, which are amino acids. Amino acids are the building blocks of proteins. So insulin also facilitates intracellular transfer of amino acids. And then lipids, they can get into the cell on their own because they're fatty and the cell membrane is fatty. So you don't need a hormone like glucose to help transfer lipids into the cell. But once the lipids are into the cell, the insulin helps to store it, because insulin is a hormone of fuel storage. So in the big picture, insulin's got many jobs. It catalyzes storage of fuel in the cell. It catalyzes the storage of fats, protein, and glucose. Further, to even get glucose and proteins into the cell, you need transporters, because glucose and proteins in the form of amino acids are water soluble and they can't cross the cell membrane on their own. So the whole global picture of insulin is it helps glucose get out of blood and into the cell, it helps amino acid get out of blood and into the cell, and lipids don't need any help getting in the cell, but then once all three fuel sources are in the cell, insulin helps store them. Glucose, if it's not burned as a fuel source, will either be converted to as glycogen and stored, or it will be converted to fat and stored. Amino acids will be converted to proteins and stored. This is protein building. And lipids will be stored as triglycerides. And you know where they wind up, right? In the buttocks, in the thighs, in the waist, wherever you store your fat. So that's what insulin does. But with relative to diabetes, we always think of it in terms of sugar, because that's like the relationship we see on the day-to-day. Okay. So because one of our primary focuses, or foci, I guess, with diabetes is to get sugar out of blood and into the cells, one of the things that we want to think about is how sugar gets into blood in the first place, because there are several mechanisms, and we start looking at drug therapy, we're going to be looking at all the different mechanisms that the drugs affect. So let's think about how glucose gets into your blood in the first place. One way, obviously, is by eating it. You can eat sugar. We all do it cheerfully every day. Most of the sugars we eat are in more complex form. They're either complex carbohydrates or even just disaccharides, right, which are two sugar molecules linked together. But when we eat sugars, we don't usually eat pure glucose or pure galactose or pure fructose. We eat sugar in more complex forms because taste is better that way. So when we ingest a sugar, it has to be broken down in the intestine, and the enzymes that break it down are called exoglucosidases. That's the whole big family. There's alpha glucosidases and other glucosidases, but alpha glucosidases are an important one because they break down dietary sucrose. And so dietary sucrose is the good stuff. This is like table sugar, domino sugar. This is the sugar that's in cakes and cookies and pies and pudding and all the good stuff, and we eat it. And we can't absorb it unless alpha glucosidases break it down. They break sucrose down into its basic parts, which are glucose and fructose. And then we can absorb those. The monosaccharides, glucose and fructose, are absorbed by the absorptive cells, and then they are eventually distributed into blood. So we can get sugar by eating it. I know sometimes this is what it feels like, right? If you eat too much sugar, you can see You ingest it in the form of either a starch, lactose, or sucrose. Lactose is milk sugars. Sucrose, like I said, that's like table sugar. That's the good stuff. And the starches are more complex, like this is pastas and breads and stuff like that. And you eat them. And the degradation process begins almost immediately. You have salivary enzymes, and then in your gut, the alpha glucosidases break them down into, like I said, fructose and glucose, and lactose breaks down into glucose and galactose. You can see if you eat too much sugar, you feel like a giant intestine. You feel like a giant bloated intestine, especially if you're lactose intolerant, then you'll really feel like that. But you get the idea. You ingest it, you break it down, and you absorb it, and then the stuff that's left comes out the other end. So that's one way that we get sugar into the body. We eat it logically. Another way is that we make it, because you don't always eat, and you don't eat all night long, so everybody fasts while they're sleeping. Some people, for all sorts of reasons, choose to fast, whether it's dietary or religious or whatever, and some people just don't eat breakfast, and you really should. But so we fast. There are times when we fast, but your body still needs glucose. In fact, there are a couple of really important cell types, like neurons and red blood cells, that can only use glucose as a fuel source. Most cells can use protein, or they can use lipids if they need to. But brain cells and red blood cells, they have to have glucose. So if you don't have glucose on board, your brain cells are going to stop functioning very fast. And like, you know what happens when somebody gets acutely hypoglycemic? What we worry about is mental status changes and seizures, right? Because the brain can't work. That's why we have to give them glucose right away. So you know you've got to have glucose on board 24/7, but you also know you don't eat it 24/7. So it makes perfect sense that we have another mechanism. And there are several mechanisms actually for making sure that you have enough glucose in your blood around the clock. And one of them is gluconeogenesis. Gluconeogenesis is the mechanism by which your liver synthesizes glucose. It makes it from non-glucose precursors. So you could never eat another carb in your life. You know, people go on these carb-free diets and like they live on lettuce and chicken or something, I don't know. It's just silly, because if you don't eat carbs, your body will make it. Gluconeogenesis, just like the name says, gluconeogenesis, sugar, new birth. It's making new sugar from non-sugar precursors like lactate, amino acids, and glycerol. So it can even take fat in the form of glycerol. And amino acids. You can eat nothing but protein for the rest of your life, and your liver will just laugh at you and make sugar out of it. So go ahead and eat carbs. You know, just eat them in moderation. So this is another way that we get sugar in blood, gluconeogenesis. And this process, it happens in the liver, and it is stimulated during fasting, prolonged exercise, high protein diet, and conditions of physiologic stress. Because either in those circumstances, either you're not putting glucose in your body, like fasting and high protein diets, or you need more than you've got, like prolonged exercise and conditions of physiologic stress. Of all the fuel sources, glucose is the fast one. Glucose is the rapid fuel. So like when you are having a physiologic stressor, or when you are doing prolonged exercise, like if you're running a half marathon or a marathon or something, you need sugar because it's a quick fuel source. So if you don't eat it, your body just makes it. And this is the way it makes it. And don't feel compelled to try to memorize this mechanism. Hopefully by now you get that I'm really not asking you to do that kind of stuff. I don't care about memorizing the mechanisms. I just want you to understand philosophically how these drugs work. So if you look at this slide from the very bottom, at the bottom of the slide, you see amino acids at the bottom, right? Which is, I was going to try and draw a little thing there, but I'm not an artist. Let me try this again. I'm going to label it number 1. Amino acids over here as number 1, and you see them over here. Here's another 1. And then glycerol, which is fat, we'll label it number 2. Bottom line is, literally at the bottom of the slide, other fuel sources go in, and then you can follow the arrows up. These fuel sources are altered, adjusted. They are morphologically changed. Pieces of them are liberated off. And at the end, what you get is glucose at the top. This is gluconeogenesis, making glucose from a non-glucose precursor. So you may as well eat it. Just eat it in moderation. Okay, So the primary ways that you get sugar in the blood is to either eat it or make it by way of gluconeogenesis. Those are the big ones that maintain like your around-the-clock sugar. There are other mechanisms like glycogenolysis, which is where sometimes we store a fair amount of glucose in skeletal muscle as glycogen, and it's there in case you have prolonged exercise and you suddenly need more glucose. The glycogen will break down by this process glycogenolysis and put sugar in your blood. But that usually is in response to like high stress, at like prolonged exercise periods. On the day-to-day, in and out, like right now, you and I, our sugar is maintained as a balance of gluconeogenesis and ingesting sugars. You ingest sugar, and then if at whatever point you're not ingesting enough or you need more, you'll make it by way of gluconeogenesis. So logically, when we want to control somebody's blood sugar, one thing we want to do is counsel them about healthy eating, obviously control the ingestion, but the other thing that we need to do is consider medicating them to help slow down this process of gluconeogenesis. Okay, next thing, insulin. Insulin is a hormone, we already established that. Its release is stimulated by meals, by high levels of circulating glucagon, by circulating amino acids, and by central nervous system stimulation. And the reason all those things stimulate it is because, again, in a 24-hour period, you have to maintain a balance of having enough glucose to do its job and then having enough insulin to put it in the cells so that it can do its job. I mean, insulin doesn't belong in, the only reason insulin is in blood is so that it's there when you need it to go into a cell and do its job. Glucose's job is to be an immediate fuel source. If you happen to eat more than you need, then you'll store it, in some other way. But that's not really what we were supposed to do. Our bodies never intended us to eat 10,000 calories of glucose a day and store most of it in our buttocks. Our bodies intended us to eat just as much as we need. It supplements it with gluconeogenesis when it has to, and then we release insulin to help us use it. So logically, like our bodies maintain an around-the-clock basal insulin level to be able to use sugar. Like when you're sleeping, you still have to be able to put sugar in your brain cells, right? So you always have a certain basal level of insulin, but then more insulin will be released when the beta cells of the pancreas are stimulated by meals, which means our glucose will go up. Glucagon is a hormone that another part of the pancreas makes, and glucagon stimulates the production of glucose by way of gluconeogenesis. So if you have a high amount of glucagons, then your body is getting the idea that you're going to have a lot of sugar floating around pretty soon. So insulin will go up. Amino acids, remember, insulin facilitates their movement into the cells too. So high levels of amino acids will make you release insulin, and central nervous system stimulation, which is typically your fear, flight, fight response. So when insulin release is stimulated, here's what happens. Oh, wait, we'll talk about what happens in a minute. We're going to talk about insulin some more here. I'm sorry. When insulin binds to a cell membrane, we're going to talk now about what happens when insulin is released. So the last slide was about insulin, what stimulates its release. Now, when it is released, it travels out into circulation all over the body. It will bind to an insulin receptor on virtually every peripheral cell, because every cell needs glucose to some extent, so every cell membrane has insulin receptors in it. And when insulin binds to the insulin receptor, it will start those processes of moving sugar in, moving amino acid in, and storing all three fuel sources. So insulin is released from the beta cell of the pancreas when stimulated by meals, high glucagon, high amino acids, etc. It's released from the beta cell, travels through the body, and then binds to a cell membrane receptor on some peripheral cell. And when that happens, your glucose and other transporters are activated, and those other anabolic actions are fuel storage. Then, once glucose is in the cell, like I said, it's either metabolized for energy, which is what it was supposed to be for, or stored as glycogen if you needed more than you ate. Okay, so here's what I thought we were coming to. So what this is showing you is this big yellow egg-looking thing is the beta cell of the pancreas. This is where insulin is made. So insulin is synthesized and stored in the beta cell, and it just waits there until its release is stimulated. And more properly, it's called proinsulin. While it's still stored in the beta cell, it is proinsulin. And what you see here is the beta cell at rest. When it's at rest, nothing is happening to it. The insulin is not being released, it's just sitting there waiting. I think the beta cell makes and stores about 70 units of insulin a day, and it just waits there, for if it needs to come out. Your needs will vary based on how much you eat and how much you exercise. So this is a beta cell at rest with insulin in it. And at rest, any cell at rest has channels open that allow potassium to leak out, and that's just the thing that maintains this cell at rest. So the important thing to remember in terms of drug therapy is that at rest, the beta cell has insulin in it. It's just waiting for something to come along and stimulate its release, and potassium channels are open. This maintains the resting state. Then, when you either eat a meal and have a lot of glucose released, or maybe you ate a high protein meal and have a lot of amino acids, maybe the beta cell has released glucagon, or the alpha cell has released glucagon, whatever happens, the surrounding amount of glucose, amino acids, and glucagon increases. And you can see that obviously here. When that happens, this is a trigger for insulin to be released. And what happens is the concentration of all these things like glucose, I know I'm circling them, which by the time you see it, it'll already be done, but glucose, amino acids, glucagon. There's other things not shown here like CNS stimulation. There's other hormones like CNS. There's other hormones like somatotropin, like lots of things can stimulate insulin release, but when they all surround the beta cell like this, what happens is the potassium channels are closed. They are closed by the concentration of these other things. You see I put a big red X around those potassium channels. When the potassium channels close, the result is that calcium channels will open and calcium goes inside. You see the direction of the arrow. And when calcium goes inside, it complexes with insulin. See if I can draw a calcium. I can't draw the little pluses though. I'm not that talented. Oh, wait a minute. Maybe I'm more talented than I thought. I know you're not seeing me draw this. It's too bad. It's kind of funny. Anyway, calcium comes in and the calcium complexes with the insulin and that pulls it out. And that's how you get insulin out of the beta cell. So again, that's the story. At rest, you have a bunch of insulin in the beta cell. It's just waiting to be needed. The cell is at rest, nothing is happening, potassium channels are open, and that's what keeps it at rest. And then when any collection of triggers happens, like you eat, you have a lot of protein, the central nervous system is stimulated, like whatever, when that happens, that will close potassium channels. And when potassium channels close, calcium channels will open, calcium will come into the beta cell, hook up with the insulin, and drag it out. And it drags it out, and then your insulin is out into circulation, helping your other cells utilize the glucose that's circulating around. There you go, insulin and calcium. I got excited, got ahead of myself here. This is a prettier picture of how it works. And you can see amino acids are in this one. So, just a lot of different triggers. Whatever those stimuli are for you to need insulin. Closed potassium channels, open calcium channels. Calcium gets in there, hooks onto the insulin, and drags it out. I promise this will all have some relevance in a minute. Then, once the insulin is out, it goes out into circulation all over the body, and it will bind to insulin receptors that are embedded in cell membranes all over the body, on your neurons, your nerve cells, your red blood cells, like every cell needs glucose. So when insulin binds to insulin receptors, and you can see the insulin here, it's like the pink egg, and it binds to the receptor. Remember week 1 we talked about receptor agonist theory. The insulin binds to the receptor, and when that happens, it activates glucose transporters. And you can see that the glucose, it's not pictured here, but what happens is that the glucose will go into the cell. Where's my arrow? The glucose will go in, and then it will either be burnt as fuel, maybe this is a skeletal muscle cell, or it'll be stored as fat. It'll do whatever it needs to do. But that's the way it gets in, is by insulin binding to it. So we have a lot of mechanisms here that, we have to think about how drugs impact them. All right, so let's look at diabetes. Like I said, you got two types of diabetes. The type where you have absolutely no insulin, and the type where you have insulin, but not enough to do the job. And that could be any amount of insulin. It could be too little. It could be the textbook right amount of insulin, or it could be the textbook high level of insulin. But if the insulin can't do the job, your body thinks you don't have enough of it. And the job is obviously what we just saw on the last slide. That is the job of insulin, to bind to insulin receptors. So when things happen that make it hard for insulin to bind to insulin receptors, your body thinks you don't have enough. All right, so keep that in mind. All right, so type 1 diabetes, this is the absolute absence of insulin. The patient has no insulin on board. They are usually born with a genetic predisposition. This is a human leukocyte antigen, and then that genetic predisposition is activated by some sort of environmental trigger. There's a lot of theories on what that might be. I honestly don't know just this minute there have been so many over the years. There was a theory that it was viral, like the Epstein-Barr virus, and there were theories about like environmental, like toxins, like heavy metals, lead, mercury. I don't know, just it changes over time, and I really don't know what it is today. I probably should have looked before I started recording, but I didn't. But what I do know to an absolute certainty is that most people with type 1 diabetes are born with this genetic predisposition. And it may be clearly evident in the family history. There may be family history of type 1, or there may not. But they're born with a genetic predisposition, and then that predisposition is activated by something from the environment. What it is, we don't know. But that accounts for why some people with type 1 diabetes are diagnosed in infancy, and other people with type 1 diabetes are diagnosed in early childhood. Other people are diagnosed later in adolescence, and some people really are diagnosed with type 1 diabetes later in life. It does happen where you will see like a middle-aged adult present with type 1 diabetes. It's most unusual because most people with the genetic predisposition will be exposed to that trigger much earlier on. They used to call this juvenile diabetes because it really does almost all the time present itself in childhood or adolescence, but not always. There is a phenomenon called adult onset autoimmune, or late autoimmune diabetes in the adult, LADA. It's LADA. Again, I'm having a TIA and I forget exactly what that mnemonic stands for. I want to say late autoimmune diabetes in the adult. That sounds good. LADA. The ICD-10 code is type 1.5, actually. Something you can read about if you're more interested in it. But my point, from which, again, I have digressed, is that type 1 diabetes, it can present any time in the lifespan. It usually presents earlier. But what it is that you're born with a genetic predisposition, and then that predisposition is activated by some environmental insult, which I believe remains not entirely known. And when you have that exposure to the environmental insult, what happens is that patients develop aggressive autoantibodies against their own beta cells. They destroy their own beta cells and cannot make insulin. And this really is a pretty fast process. It does take a little while. If the patient happens to be diagnosed early in the process, they will probably spend several months where they go up and down in terms of their sugar and their insulin requirements. But you can bet for sure that within a year of diagnosis, the patient is going to be completely 100% dependent on exogenous insulin administration because they won't be making any of their own. This is the patient with no insulin. And from a pharmacology perspective, they're actually easier because the treatment for them is insulin, right? We just give them insulin, and we give them insulin in the way that the body would do it if it could, which is a basal insulin in the form of a long-acting or an ultra-long, like, Levemir or Lantus or Tradjenta or something like that. A long-acting to maintain around-the-clock basal insulin, and then pre-meal boluses of short-acting insulin to act the way the body would act if it could. In type 1 diabetes, the pancreas fails entirely to respond to any of that insulinogenic stimuli. So remember we were looking at that picture where the beta cell is surrounded by glucose, glucagon, amino acids, what else? Whatever else, central, somatotropin I mentioned, that those are the stimuli to release insulin, and the pancreas just completely fails to respond to it. There is a bullet point here. It's worth mentioning, I guess. A very, very small subset of people with type 1 diabetes, it's not autoimmune. Nobody really knows what causes this. There is a very small fraction of people. You could go your entire career and actually never see one. Very small subset of people who do have a complete absence of insulin, and nobody knows why. There's no antibodies. You can tell the difference, and some of you may or may not have experience with this, but when patients have type 1 diabetes, part of the diagnostic evaluation is to test them for those antibodies that they've made against their own beta cell. There are GAD65 antibodies, there are islet cell antibodies. I'm sure there's a ton of them now. They find new ones all the time. But you can actually measure these antibodies, and that's how you know the patient is making them, and that confirms your diagnosis of type 1 diabetes. There is a very small subset of people, there is a small subset of patients who make no insulin at all and no antibodies at all. And nobody really knows why, but all you can do is just treat them with insulin. So that's type 1. Of all the people in the world with diabetes, I think statistically like about 10% of them have type 1. In type 2 diabetes, this is the common one. Type 2 diabetes is the type where you do have circulating insulin, but you have a relative deficiency. So you have enough to prevent acidosis, but you don't have enough to do all of insulin's jobs, and it becomes evident because it can't prevent hyperglycemia. Just a note on the acidosis if you don't understand that mechanism. I know this isn't a patho class. Sometimes the lines get blurred, but in type 1 diabetes, because there is no insulin at all, the body is completely unable to metabolize glucose as a fuel source. So the only thing it can metabolize is fat, because remember, fat can get into the cell without a transporter. So you're burning fat 24/7 as a fuel source, which keeps you alive for a little while, but the problem is when you burn fat and break it down, you produce acid as a byproduct. And if you're doing this 24/7, you have no other fuel sources but fat, you'll burn so much fat that eventually you'll make more acid than you can excrete, and the patient will become acidotic. And that's usually how we diagnose them, because when you get acidotic, you get all mental status changes and stuff, and you're going to show up in an ER somewhere. In type 2 diabetes, because there is some insulin, you're not having to burn fat 24/7. You still can use some glucose as a fuel source, so you're not making all this acid, so you don't become acidotic. That's why it's a lot harder to diagnose type 2 diabetes. Most of the time, we don't find it until we just do a screening for somebody. So that's what I mean when I say in type 2, because there is some insulin, remember there's a relative deficiency, not an absolute deficiency. Circulating insulin is sufficient to prevent acidosis, but inadequate to prevent hyperglycemia. So over time, the patient will become hyperglycemic, and all of the consequences of hyperglycemia happen. The reason that type 2 diabetes happens, the overwhelming majority of the time, is that the patients have peripheral tissue receptor insensitivity. Remember, that last graphic we looked at was how insulin, after being released from the beta cell, goes out and binds to a peripheral receptor somewhere and then facilitates intracellular movement and storage of glucose. The problem with type 2 diabetes is there's something wrong with that receptor. Nothing wrong with the insulin, nothing wrong with the beta cell. The problem is with the receptor. The receptor doesn't work right. And this can happen for years and years and years before the patient actually gets diagnosed. And the most common reason for it is that the patient is obese. So think about what's happening here. If somebody is obese, they're going to accumulate like excess stores of fat inside the cell as well as outside the cell. And if you accumulate too much fat inside the cell, it stretches out the cell. It distends it. And when the cell gets distended, it distorts the cell membrane because the cell membrane is just made of fat. So it distorts the cell membrane, and all of the receptors embedded in it will get distorted. Again, I'll hearken you back to week 1 or week 2, probably week 1, when we were talking about receptor agonist theory, and I said that you get these membrane proteins that are embedded in the cell membrane, and they serve as receptors. So the membrane is a lipid, and when it gets stretched out, the receptors get stretched out too. And that's what happens when you are obese. You get intracellular accumulations of fat. And those intracellular accumulations of fat distend the cell, and they will distort the shape of the receptor. And when the shape of the receptor is distorted, insulin can't fit in it. It just can't work. It's like if you have a lock and a key, and the lock gets all banged up. Like maybe some of you when you were little had those little strong boxes, like your little secret box, and you have a little key that opens it. And then if you have a big brother like I did who tries to break into your box, he might, get at it, like bang it around, get at it with a hammer or something, and succeed in doing nothing except messing up that lock so that now your key doesn't work either. That's exactly what happens with these insulin receptors. They get distended by fat cell accumulation, and when they get distended, the shape of the lock is all messed up. So insulin as the key doesn't work anymore. So what do you do when your key won't work because your lock is all messed up? You assault that lock with that key. You stick it in there, wiggle it around, jam it around, maybe tilt the box a little bit. I mean, we've all had that experience where a key won't work the first time you use it. So what do? You become determined to make it work. You wiggle it around, you jiggle it, you pull it out of the lock, you put it back in, and half the time it works, right? Half the time, eventually you get it to work. This is exactly what happens with type 2 diabetes. The cell membrane gets distorted, insulin won't work, so what the body does is assault it with insulin. It just, now the beta cell, remember, is fine, and your insulin production mechanisms are fine. So if insulin doesn't work, what your body will do is make more insulin and start throwing insulin at it. And, well, let me go to the next slide here before I get too excited. Yep. So here's what happens when the key won't work in the lock. The cells perceive this as hypoglycemia because your cells can't get any sugar in. So a bunch of stuff happens. One of them is that you start making more glucose. Gluconeogenesis cranks up, right? Now, your body is still throwing a bunch of insulin at this cell. So now what you've got is a patient who is obese, hyperinsulinemic, and for a little while the elevated insulin works, just like for a little while when you can beat up that lock with that key and make it work. So for a while, even before the diagnosis of diabetes, the patient will be obese, have elevated insulin levels. If you drew an insulin level, it would come back as high on the scale, and the sugar will be normal, so they're not diabetic yet. But eventually, a few things happen. Number one, the beta cell just can't keep up this production of high levels of insulin forever. Eventually it'll crap out. And also, because your body thinks you don't have enough sugar, all it knows is there's not enough glucose in the cells to do its job. So your body thinks you're hypoglycemic. So your liver cranks up gluconeogenesis. So now you're stuck in a situation where you're hyperglycemic, but your body doesn't know it. So it's making more sugar, and it's making more insulin because the insulin doesn't work and is burning out the beta cell. So what's the bullet points here say? Now, not only does dietary sugar stay in plasma because there's not enough insulin to move it into the cell, but gluconeogenesis is putting even more glucose into plasma. I hope you can get a sense of what's going on here. Insulin resistance is the dominant early feature. A post-receptor defect in insulin action is the initial problem due to over-distended visceral fat deposits. I'm just going to go along with the slides here and then try to put it together at the end of the discussion. Yep, obese type 2 diabetes, it is the most common one. Begins with decreasing sensitivity of peripheral insulin receptors from mechanical deformation of the insulin receptor due to the obesity. This is what happens. The insulin receptors just can't work because they're all distended because the intracellular environment is fat. See, this is what's supposed to happen. This little picture to the right-hand side. What's supposed to happen is you have glucose transporters like GLT4 you see over here. And those glucose transporters will be activated when insulin, which you see on the left, binds to insulin receptors. When insulin binds to insulin receptors, it will send over a signal to the glucose transporters to open up, and then the glucose will let it in. But if you have an insulin receptor problem, like I'm circling here, if there's a problem with these receptors, it can't open the transporters. And so then you're going to have a lot of insulin out here trying to make this work, and a lot of glucose out here because it can't get in. And patients will be hyperinsulinemic and hyperglycemic. And this characterizes the years before diabetes. Oh, I did it again. Let's look at your next slide. Progressive insulin receptor insensitivity stimulates the beta cells to produce higher levels of insulin. Higher levels of insulin are adequate to maintain normoglycemia for an extended period. Estimates are that hyperinsulinemia with normoglycemia occurs for up to 10 years. Okay, let's look at the picture. This is what's happening in diabetes. So let's see. First of all, I'm going to draw your attention. I'm going to circle it in purple here. This is the point at which the patient gets sugars high enough. No, purple doesn't work. Let me find a nice, big, bright color here. Oh, maybe white will stand out. This is the point that I'm circling in white at which the sugar gets high enough where the patient will be diagnosed with diabetes. Notice that this abnormal process has been going on for 10 years before the sugar gets high enough. Because here's exactly what happens. You start out life at a normal weight. I mean, year zero isn't necessarily how old you are. This is just the beginning of the problem. This could be at 40 years old or 50 years old or any years old. It could be an adolescent. It could be anything. But year zero just refers to the fact that this is where we start tracking the phenomenon. At year zero, what you can see is you're making relatively low levels of insulin. That's the green line. Right? Relatively low levels of insulin because you don't need it. You don't need a lot of it because your insulin receptors are working just fine. Your insulin receptors are great. So you release a little bit of insulin. It facilitates movement of glucose into the cell. So your glucose stays normal. That's your red line. And I circled that at the beginning. And life is good. This is the healthy, non-diabetic patient. Then what happens is as the patient starts to accumulate weight, the patient starts to accumulate intracellular fat deposits. The insulin receptors start to get distended and they become less effective. So as the insulin receptors become less effective, glucose doesn't move in as effectively, and you'll see the glucose start to rise. And you can see this red line start to creep up a little bit. As the glucose starts to rise, the beta cells, which are working totally fine, they're like, oh, there's a problem here. We're having intracellular hypoglycemia. We need to make more insulin so that insulin can open up those glucose transporters. So then what you see is the green line really crank up as the patient starts producing enough insulin to keep the sugar normal. And then for years, here from like year 2 to year 10, your body manages to control itself. It takes increased levels of insulin, which you see by this green line, like this steady state green line. The green line's not really moving much. You start making more insulin. If you measured the patient's serum level at this point, their serum insulin level, it would be elevated because they're making, as you can see, a whole lot more now, and I'm putting a 1 here, than they did before they developed a problem, and I'm putting a 2 there. So they're making a lot more insulin, but that's okay because the beta cell can. It's making supraphysiologic levels of insulin, and if you measured it now, it would be high. But this is enough insulin to keep the sugar under the threshold of diabetes. It keeps the sugar normal. The patient is normoglycemic, and if you did a hemoglobin A1C, it would be fine, and that's what I'm labeling as 3. So for this big period here from year 2 till year 10, you can see that insulin levels are high and it's keeping sugar levels normal. But eventually, the beta cell just can't keep it up. So somewhere around year 10, the beta cell finally begins to burn out. And when the beta cell burns out, then you see insulin levels start to drop, and I'm labeling that as 4. And when insulin levels drop, now you've got a circumstance where the body for years has become accustomed to having high levels of insulin. It needs a lot of it now, and it doesn't happen. So now that it doesn't have enough insulin, the sugar really starts to rise, and I'm labeling that as 5. And the big one at 6. So it used to be back in the day, we didn't even find out people had diabetes until they were like at 5 or 6, because that's when their sugar came up. Now we're checking them earlier by way of screening, so we hope to find them somewhere in this period, like, around sometime during what I have labeled as 3. The earlier the better, of course, so we can start to intervene before the beta cell craps out. We really like to treat people before that beta cell starts to become non-functional. So let me just give you one more hormone here, and then we'll summarize it and then look at drugs. All right. No, I'm sorry. Before we get to the hormone, there's one little slide that I have to. My list of slides is constructed a little bit differently than yours. That's why I sound scattered sometimes. There is just one slide that I want to mention to you. Again, this is something you may go an entire career and not see. Just like, remember, I said a very, very, very small fraction of people with type 1 diabetes did not have autoantibodies. It wasn't autoimmune, and we didn't know what it was. And you could go a whole career without seeing them? Well, that's true. And we have a parallel here in type 2. There is a phenomenon of non-obese type 2 diabetes, much less common. But in these patients, the primary problem is beta cell dysfunction. Not absolute failure like type 1. These patients do still make some insulin. That's what makes them a type 2 diabetic, but they don't make nearly as much as they need. So they lose their sensitivity to insulin triggers. Not 100%, it's not type 1, but they lose their sensitivity. These people are, it's really obvious that they're different. They tend to be actually quite petite. Almost everybody with type 2 diabetes, it's because of intracellular fat accumulations. Almost everybody is considered obese type 2 diabetes, even if they're not overtly what you would call obese. Even if their BMI is just like, 25 or even 24, 25, around there. If they're diabetic, it's type 2. But every once in a blue moon, you'll come across these patients, and I believe this is more common in the Asian population than anything else, where you get a really petite patient. I've only seen one in my entire career, but you'll get a really petite patient. Often the BMI is like, 20 or 21, and that patient has type 2 diabetes. That's this. It's not about intracellular fat accumulation. It's about that for some reason their beta cell is not responding appropriately. It does matter because their drug choices will be different, but this is a very isolated subset of the population. All right, now back to the last hormone. And this is incretin. The role of the incretin hormones was it really sort of blew up like in the 21st century when everybody realized how important it was in diabetes management. So incretin refers to the intestinal secretion of insulin. There are intestinal triggers for insulin secretion, and the incretin hormones, that's their role, and there are 2 major intestinal incretins, 2 major hormones in the incretin family produced by the small intestine. And they are GLP-1, glucagon-like peptide, and glucose-dependent insulinotropic polypeptide, GIP. This is the artist formerly known as gastric inhibitory peptide. The one that's really relevant to our discussion is glucagon-like peptide, or GLP-1, because glucagon-like peptide does an awful lot to help control the post-meal bolus of glucose that winds up in most people's bodies. So GLP-1 is secreted by the small intestine in response to ingested nutrients. When you eat a meal, and it has to be something with nutrients in it, like a giant bowl of fiber, like a glass of Metamucil, that won't do it. It has to be a meal that has what do you call it, nutrients in it, and it's mostly about carbs. So when you eat a carb-infested meal, your intestine will become distended and it will release glucagon-like peptide. And glucagon-like peptide goes on to do several things that will control the sugar that you ingested with that meal. And we'll look at those in a minute. It doesn't last long because its primary goal is to help you digest the sugars that you just ate. So after a short time, DPP4 is a naturally occurring enzyme that will break down GLP-1 so that it stops working. So it makes perfect sense, right? If you're, like I said before, there's a lot of different mechanisms that go into play in controlling your sugar around the clock. This one is about the post-meal sugar. So just think about it. You eat a big meal, you eat a big bowl of pasta, got a lot of carbs on board. You distend your intestine. The intestine releases GLP-1. The GLP-1 does a bunch of stuff that helps you digest that pasta. And then as soon as it's digested, the DPP4 enzyme breaks down GLP-1 so that you're not doing this stuff anymore. And then you get hungry again. It's time for the next meal. It's just part of the normal cycle. This is what GLP-1 does to help you in the post-meal phase. It slows down gastric emptying, number one, which makes you feel full, which means you won't eat again for a while, at least if you listen to your body. When your body tells you you're full, stop eating. That's part of what GLP-1 does. GLP-1 suppresses glucagon secretion in a glucose-dependent fashion. In other words, the presence of GLP-1 suppresses glucagon release from the alpha cell of the pancreas because your body thinks you have it already. It's glucagon-like peptide. If you don't make glucagon, you won't liberate more sugar from your body stores. Remember, glucagon is a hormone that helps you liberate sugar. The presence of glucagon-like peptide makes your body think you have plenty of glucagon. So it suppresses natural release of it. So the bottom line is this hormone, this incretin hormone GLP-1, makes you release less glucagon, which makes you release less glucose. Okay. It also, GLP-1 also enhances glucose-dependent insulin secretion. So now your beta cell is stimulated to make more insulin, which you need to digest the sugars you just ate. It also enhances beta cell proliferation. Beta cells are the cells that make insulin, and GLP-1 actually helps to proliferate them and decreases beta cell apoptosis, which is a mechanism of destruction. So it preserves beta cells, helps them proliferate, and keeps them from breaking themselves down. So this GLP-1 hormone collectively works together to make you feel full, stop you from eating, stop you from releasing glucagon so you don't make more glucose in blood, stimulates insulin release so you can digest the foods you just ate, and actually cranks up your beta cells to make that insulin. So GLP-1 is awesome. It's just that patients with type 2 diabetes don't make enough of it. This is one of the first things we appreciate in patients with type 2 diabetes is that their intestinal response to a meal is blunted. They can't make enough GLP-1. So think about it. If you can't make enough GLP-1, then after you eat, you won't have the hormone that stimulates beta cells to release insulin. So you can't use the sugar you just ate and you'll become hyperglycemic. You also don't have this hormone that suppresses glucagon. So you're going to make more glucagon, and glucagon is going to make your liver make gluconeogenesis, so you're going to have more sugar there too. So you just have a bunch of sugar and you can't use it. That's what happens when you don't have enough GLP-1, and that's what happens in patients who have type 2 diabetes. Oh, here's a picture of all the things that GLP-1 does. So it shows you, let's do some labels. Let's see, label 1, GLP secretion. So like I said, stimulated by food intake, and you release it from the intestine. And it is diminished in impaired glucose tolerance in diabetes. So most of us have it, but if you have diabetes, you have less of it. Once you eat and you release GLP-1, it does all of these other things. Number 2, enhances glucose-dependent insulin secretion. Number 3, helps regulate gastric emptying so you feel full for a while and don't eat again. 4 reduces glucagon-mediated hepatic gluconeogenesis. Decreases number 5, glucagon-like production. And then it doesn't label it here, but it also helps, like I said, beta cell proliferation and suppresses apoptosis. And it even tells your brain you're full, stop eating. So GLP-1 is important, and type 2 diabetics don't have it. Think about that when we look at drugs, which I promise we're going to do like in just a minute. Here you go. This is a graphic that just shows you how this GLP-1 release is blunted in patients with diabetics. So you've got 3 people plotted here. People in blue are those that have diabetes. People in red are those with impaired glucose tolerance. So their sugars are high, but it doesn't rise to the level of diabetes yet. And then you have the yellow, which is normal glucose tolerance. These are the non-diabetic patients. And you can see that after a meal, so like time 0 is like as you are eating. And then 60 minutes is, 60 minutes after a meal, 120 is 2 hours after a meal, etc. And you can see what happens. Everybody's, excuse me, everybody's GLP goes up a little bit, but the people who are normal glucose, they get the highest GLP-1 and it lasts for the longest amount of time. People with impaired glucose tolerance, they'll make a little GLP-1 right after they eat, but the levels decrease pretty fast. And then people with diabetes, they will peak out like less than an hour after they eat, but very fast their GLP-1 secretion goes down. So it's become an important part of designer drug therapy in the 21st century. All right. There are numerous drug choices now in the management of diabetes, and they target different pieces of any variety of these hormonal cascades. Understanding proper selection requires understanding the patho, which is why we just talked about it for almost an hour. So all it really comes down to is, with type 1 diabetes, you have to replace the insulin. So that's easy. You just, replace, it's just the insulin. The patient doesn't have any. We give them insulin and that's it. And the primary safety issue is about hypoglycemia and teaching people how to safely use needles and to monitor themselves for hypoglycemia. From a pharmacology perspective, type 1 diabetes is much easier. For type 2 diabetes, the patients have some insulin release, and in fact, there might be quite a lot of insulin on board depending when you make the diagnosis. In terms of type 2, what we're talking about, remember, is somebody probably is obese, and so their insulin receptors don't work right. The lock and the key, the insulin doesn't work right. And when the insulin doesn't work right, the body responds by releasing more of it. And when you have more insulin, we're trying to make it work. One of our most important drug therapies are drugs that help the insulin work more effectively, that sensitize the insulin receptor. We want to preserve the beta cell, right? Because the more hyperglycemic somebody becomes, the more intracellularly hypoglycemic they are, and then the body thinks they're hypoglycemic and it keeps cranking out more sugar, and it just becomes a giant mess. So let's take a look at some of these drugs. They are loosely categorized into 2 primary groups, those that stimulate insulin release from the beta cell and those that don't. Now keep in mind, if you think about the trajectory that we've just talked about, it makes sense that especially if we catch the patient early enough, we don't really have to make them release insulin. They're releasing more insulin than normal. The primary issue is making the insulin more useful, right? But eventually, the patient will get to that place where the beta cell doesn't make enough insulin, or maybe they're making a quote normal amount, but we want them to make even more of it. So there's definitely a time to use medications that help stimulate insulin secretion, but not always, and it's something to think about. On the other hand, we have a whole collection of drugs that don't stimulate beta cell release of insulin. They work on some other impact of this abnormality, some other place in this abnormality. The reason that matters is the insulin stimulators or the insulinogenic drugs, their primary safety issue is hypoglycemia. Obviously, if you give a patient a drug that stimulates beta cell release of insulin, there's a potential for becoming hypoglycemic, and it's an important patient, safety discussion. So Of the insulinogenic drugs, there are two. The sulfonylureas are the first ones. I mean, these are the oldest class. They've been around forever. In fact, when I first started teaching, these were the only drugs that we had for type 2 diabetes. Metformin was just getting approved in the United States. So these insulinogenic drugs, these sulfonylureas have been around forever. They're the oldest anti-diabetic agent in use. They are highly effective when used properly. But the thing to keep in mind is that they do make the beta cell release insulin, and when you metabolize them for excretion, even the metabolite is active. So these drugs are working right up until you flush them out of the body. So if there's any renal dysfunction, if there's going to be any problem with metabolism, it's very easy for these patients to become hypoglycemic because there's too much of this drug on board. So let's see. These work by stimulating the beta cell. That's just what this shows you. These drugs work by stimulating the beta cell, and what they do is block those potassium channels just like natural stimuli would. Remember back when we were talking about how the beta cell releases insulin? I said the beta cell makes insulin and stores it, and it just stays there in a resting state waiting for a stimulus. And in the resting state, potassium channels are open, and insulin stays in the cell, and life is just a big rest. And then when all those stimuli came along like glucose, glucagon, etc., they blocked the potassium channels, and the act of blocking the potassium channels opened calcium channels and let calcium in to carry the insulin out. Well, these drugs, the sulfonylureas, they block potassium channels, so that's what they do. The other group of insulinogenic drugs are the meglitinides. The meglitinides, you may not hear so much of them. They were a little bit of a flash in the pan. I believe there's only two on the market, repaglinide and nitaglinide. These were marketed as Prandin and Starlix. Repaglinide is Prandin, nitaglinide is Starlix, and they work in very much the same way. They block potassium channels, they facilitate pancreatic release of insulin, and their claim to fame was that, number one, they were metabolized to an inactive metabolite, so they were safer in renal dysfunction. Another claim to fame was that they were much more rapid acting, so they were better able to mimic what the body normally does after a meal. And that they only released insulin in a glucose-sensitive manner, so that you were theoretically less likely to become hypoglycemic. I don't know. I mean, I guess those claims to fame never really panned out all that much. Like I said, they were a bit of a flash in the pan several years ago, but I don't see them used routinely, so I don't know if you will either. But that's how they work. Those two classes of drugs, the sulfonylureas, which you would know as glyburide, glipzide, amyryl, diabinase, there's a bunch of them out there. Those are the sulfonylureas. And then the meglitinides, those two classes of drugs are insulinogenic. They stimulate the beta cell to release insulin. And the big implication there is that from a safety perspective, they can make the patient hypoglycemic. So primary patient teaching has to be around recognizing hypoglycemia, what to do if it occurs, and when not to take these medications, like if you're going to be NPO for some reason. All the other drugs that we have for diabetes for type 2 diabetes are non-insulinogenic, meaning they don't stimulate the beta cell. And so the primary issue there is that hypoglycemia is not a concern. Sometimes if you look it up in a drug book or you read a package insert, in tiny little print it will say, may cause hypoglycemia when co-administered with insulin or some silly thing. You know, because everybody just worries about covering their butt all the time. Of course, if you give a drug with insulin, if you give a drug that helps insulin work with insulin, there is a risk of hypoglycemia. But if you give it on its own, it really isn't likely. That's okay. There's plenty of other side effects we have to consider. So let's see what we got here. The majority of drugs used to treat type 2 diabetes do not directly stimulate the beta cell to release insulin. Primary side effects in most cases even I'm protecting myself legally, primary side effects in most cases do not include hypoglycemia, so we want to understand these mechanisms. Of course we do. It's why we're here. All right, so let's look at metformin. Metformin is the first drug anybody with type 2 diabetes will be put on, so I'm sure that it's a big part of most of your day-to-day because so many people that are hospitalized have have diabetes. That's what I'm trying to say. So metformin is always the first go-to drug. Look at its mechanism of action. Metformin's primary mechanism of action is the suppression of hepatic glucose production. Now remember what I said when we were talking about the physiology of glucose homeostasis. I said that gluconeogenesis is the liver's way of making sugar from non-sugar precursors. And the reason it needs to do that is because you always need to have sugar on board for like your brain cells and your red blood cells and any cell who requires glucose to work. You need to have them even if you don't eat sugar. So gluconeogenesis is that mechanism of synthesizing glucose from non-glucose precursors, which is awesome. Except that when you develop diabetes and your insulin receptors are not as responsive, your body perceives this as hypoglycemia. And what does your body do in response to perceived hypoglycemia? It makes more sugar. So increased hepatic gluconeogenesis is an important part of the pathophysiology of diabetes, and metformin suppresses that. What else does it say? Basal hepatic glucose output is the primary determinant of elevated fasting blood sugar, and that's a true story. It's because your body thinks you're hypoglycemic because your insulin doesn't work, like I just said. So you crank up gluconeogenesis. Metformin also reduces fasting plasma insulin and improves insulin sensitivity. That's the other piece of the mechanism of action. So if you're thinking about what's wrong in diabetes, it just becomes so obvious why metformin is the #1 drug. The primary problems in type 2 diabetes are that your insulin receptors don't work, so your body thinks you're hypoglycemic, so it makes more insulin and it makes more glucose by way of gluconeogenesis. So we have this drug that can sensitize insulin receptors and make your insulin more effective, and suppresses gluconeogenesis. Boom! I mean, you just went at the two primary things that are wrong in type 2 diabetes, especially early in the disease. If you get metformin on board, you make the insulin they have more sensitive. Sorry about that. That's the third time I recorded that slide, so I'm not going to go back and do it again. I'm just going to turn off the phone here. Lost my train of thought, but I think you knew what I was talking about there. So metformin gets those two primary things. That's why metformin, always #1 drug. Next class of drug, this is another one that you won't see so often, the alpha-glucosidase inhibitors. This targets ingested sugar. Remember I said the two primary ways you get sugar in your body is to eat it or make it. Metformin controls the insulin you make. Alpha-glucosidase inhibitors controls the amount of glucose that you absorb. So they exert their mechanism of action in the gut by preventing enzymatic hydrolysis of the sugars that you eat. Remember, you eat complex sugars or disaccharides, and then alpha-glucosidases break them down into fructose and glucose so that you can absorb it. So logically, alpha-glucosidase inhibitors are going to block that. These are useful as an additive therapy. They're not huge in terms of their impact. You're not going to get gigantic reductions in blood sugar with an alpha-glucosidase inhibitor because all these do is block the amount, they decrease the amount of sugar you absorb. Here's a little picture. So let's see. When you eat sugar, you eat it in the form of sucrose in the blue side or lactose in the white side. And sucrose you can see is a disaccharide. I'm circling it. Two sugar molecules together, and lactose is a disaccharide, two sugar molecules together. You can see that it's two sugar molecules linked, right? And then when you hydrolyze these, or when you break them down, which is what alpha-glucosidases do, you break down sucrose into two separate forms, glucose and fructose, and you break down lactose, which is milk sugar, into galactose and glucose. That's how you can absorb it. So the alpha-glucosidase inhibitors just inhibit this process and makes it harder to absorb. So it's nice because they're not, these drugs are not absorbed in the body, so they're not going to have like any major adverse effects in the body. But of course, like most drugs that have no major adverse effect, their effect is actually not as strong. So they're not going to have these huge reductions in sugar. They're kind of like an add-on therapy. The thiazidinediones are the next class of drug. You probably know these. They are marketed as Actos and Avandia. They're the two ones that are on the market now. These drugs are primarily targeted to increase insulin receptor sensitivity. They make these receptors, and I'm circling them in red, more responsive to glucose. So it's really nice, especially if the person really has an insulin receptor problem, like maybe they're really obese and you just can't get their sugars under control any other way. You'll see patients on thiazidinediones. This drug class has been sort of plagued with a side effect profile that makes them not anybody's favorite anymore. The safety issues you have to consider with the thiazidinediones include things like they promote increased fluid retention, so you worry about exacerbating congestive heart failure. There's even some links to increased incidence of coronary artery disease. You always have to be watchful of liver function. Not that these drugs really hurt the liver any more than any other drug, but years ago, the first drug put on the market in this class was called Resulin. And it turned out to be really hepatotoxic, and there were lots of liver-related deaths and liver transplants. In fact, before Resulin came off the market, we had to do LFTs every 2 weeks. So it was a difficult drug. Actos and Avandia are newer generations of that class, and they really tend to be just, as safe as any other, but they just got a bad rap from their parent drug, Resulin. So we always pay attention to the liver. And there's some correlation apparently between Actos and bladder cancer. So these poor drugs just can't win. But they are very effective in reducing insulin, improving insulin receptor sensitivity. So you'll see these as an add-on too. That's all they do. They don't really suppress gluconeogenesis like metformin does. Now the incretin mimetics are, like I said, the 21st century explosion in anti-diabetic drugs has really focused on drugs that affect that incretin cascade. Remember the cascade. After you eat a fuel-infested meal, you distend your intestine and it releases GLP-1. And GLP-1 does many things that helps you metabolize that meal. It slows down your gut. It tells your brain you're full. It makes you release insulin. It suppresses glucagon, and it causes beta cell proliferation, right? And we said that people with and then we said that DPP-4 will break it down. We also said that people with type 2 diabetes don't have enough of this. So now we have a couple of classes of drugs that will impact this cascade. One of them is called the incretin mimetics. This is synthetic GLP-1. It's fake GLP-1. So it does what GLP-1 does because it's fake GLP-1. So it does all these things. You give GLP-1, it stimulates insulin release, it inhibits glucagon. These will lower blood sugar. But then eventually DPP-4 will break it down. It's just the way it's supposed to be. I mean, these drugs basically, they just do what GLP-1 would do if the patient could make it. So I guess this is what it does. Stimulates glucose-dependent insulin secretion, lowers glucagon, slows gastric emptying, all that stuff I already said, which will suppress the appetite. In fact, a lot of times people complain early on about nausea with these drugs because when you slow down GI motility, sometimes it can make you feel nauseous, certainly give you a sense of early satiety. Anticipated hemoglobin A1C reduction is 1 to 2%. These are more effective than some of the other drugs. And yes, big dropout rate due to nausea. In terms of safety with these drugs and adverse effects, you really want to think mostly about, in terms of adverse effects and patient education, it's really about nausea. That's the thing that people complain about the most. From a safety perspective, because they stimulate the beta cell, remember I said it causes beta cell proliferation and decreases beta cell apoptosis, which is destruction. So it preserves beta cells and actually stimulates them to divide. So people that already have pancreatic problems, it can be exacerbated by this. So people with chronic or even acute or chronic pancreatitis shouldn't take it. People with pancreatic cancers or strong risk for pancreatic cancers shouldn't take it. So those are the primary safety issues. But for everybody else, they are effective. It's a fake hormone. You know these are injectables. Victoza and Byetta are among the two most famous ones, but there's a few of them out there. I can't think. Good grief, I can't think of some of the other names, but these are injectable. They're non-insulin injectables, and they're called incretin mimetics, and they do what incretins would do if you had them. Now we have another class of drug that works a little bit differently in this same cascade, and those are called the DPP-4 inhibitors. The DPP-4 inhibitors, remember what I said about how this normally works in the body. We all make GLP-1, and GLP-1 does its job, and then DPP-4 breaks it down, right? Well, we have DPP-4 inhibitors, which it's not fake GLP-1 like Victoza. DPP-4 inhibitors are drugs that inhibit the action of our naturally occurring DPP-4, which means our own naturally occurring GLP-1 gets to hang around a little bit longer. So there are two different drugs. GLP-1 mimetics are fake GLP-1. That's Victoza. So you don't have to have any GLP-1 of your own. You just get a shot and, get it administered. If you take a DPP-4 inhibitor, you block your own enzyme that breaks down your own GLP-1. So the good side is you're not giving a synthetic hormone, you're just allowing the body's natural hormone to hang around longer and do its job. You're enhancing endogenous GLP-1. That's the good part, because whenever you give a fake hormone, the side effect profile is always stronger. We're just not as good as making hormones as the body is. So when we give a fake hormone, it's going to have more oomph. So the good thing about DPP-4 inhibitors is that you're letting the body just use its own GLP-1. The downside is you still have to have some GLP-1 on board to do it. If you get somebody later on in the trajectory of type 2 diabetes, they've had it for many years, they just may not be making enough of their own GLP-1 period. So even if you block its breakdown, it's not going to be enough to make a huge difference. So the upside is facilitating a naturally occurring hormone is just safer. It feels better. The side effect profile for these is very rare. The downside is they're not as efficacious. They don't have as much juice as an incretin mimetic. And these drugs are oral agents. These are not, These aren't injectable. These are oral. Januvia was one of the very first ones. I'll correct this before you see it, but I'm hesitating because my slide has it badly misspelled, but I'll correct that before you see it. Januvia was the first one, and then Onglyza, I don't know who came up with that name, but Onglyza is another one, and then there's Tradjenta. These are oral agents, and as I say, they inhibit your own DPP-4, which allows the patient's own GLP-1 to hang around longer. Less side effects, less profound effects. They just don't lower A1C as much. Then we have this other drug, pramlintide. I don't know if you'll ever see this or not. This is another one that was kind of a flash in the pan. So amylin is another hormone in the glucose homeostasis cascade. And you can see the bullet point here says amylin is a hormone normally released with insulin along from the pancreas. And amylin also modulates gastric emptying, also prevents postprandial glucagon, makes people feel very full. That's producing satiety. So it really is awesome for weight loss because you just don't want to eat as much. This one can be used in both type 1 and type 2 because it really doesn't directly impact insulin. It doesn't require a functioning beta cell. All the other drugs we talked about require a functioning beta cell. But there are some safety issues with pramlintide. This was marketed as Simlin, and you have to eat X number of carbs to use this. It's just another one that I don't see used very much anymore. Another, proverbial flash in the pan. But if you see it, remember that diet management is a real issue here. The patient has to eat a certain number of carbs a day to be safe with this. Otherwise, they can have symptomatic hypoglycemia. The last class of drug in the type 2 diabetes arsenal, and they're using this for type 1 now too, are the sodium glucose cotransporters. So these are newer. You'll see commercials on TV, ladies running around in flowery dresses talking about how great they feel ever since they started taking Farxiga. Invokana, Farxiga, and Jardiance. These are the two I know about. Invokana was the first one, and it never really caught on, and then these other ones came out, so we'll see. But what they are sodium glucose cotransporters. So here's what they do. They facilitate renal excretion of sodium. They offload sodium. And if you watch the commercials on TV, like when the dancing lady is talking about how great it is, she says, because it only works when my blood sugar is high, which is true. These drugs will not make you hypoglycemic. They act on postprandial hyperglycemia, and they just facilitate proportional offloading of sugar in your urinary tree. So if your sugar is high, this makes you excrete it. And obviously it's been through all the FDA safety testing, so it must be fine. I always hesitate a little bit with these drugs just because, the body tries very hard to keep sugar out of urine. That's why there's not supposed to be glucose in urine, in healthy urine. Because when you put glucose in urine, it's a magnet for bacteria and it can really increase infection and, blah, blah, blah. So now you have these drugs who work by putting sugar in your urine. So obviously they're contraindicated in people that have chronic UTIs, high risk for chronic UTI, high risk for pyelonephritis, where the infection can ascend from the lower urinary tract up into the upper urinary tract. Just got to be on the lookout. That's the primary safety issue there, is the consequences of sugar in the urine. There are FDA warnings about diabetic ketoacidosis, and which is a little bit counterintuitive if you think about using this for type 2 diabetes, because with type 2 diabetes, we don't expect diabetic ketoacidosis. But I was reading some of the FDA advisories about this, and it sounds like, number one, it is used in type 1 diabetes, and it may be that you see diabetic ketoacidosis disproportionately in type 1. But the other impression I got was that they might have been being used in patients that were diagnosed as type 2, but were actually late adult diabetes, like latent, whatever I said LADA stands for, latent autoimmune diabetes of the adult. Yeah, I like that. So in other words, these were given to people that their prescriber thought they had type 2, but they really had type 1, and then went on to develop DKA. So I don't know what the story is there. I do know that there are FDA advisories about DKA with these drugs, so I have to pass that on to you. But seriously, mostly I'd be very careful. When you're monitoring your patients and stuff, if they're on these drugs and you have any concerns about urinary tract infection, do address this with the prescriber. This may not be the best drug for that patient. And I think that's all I got. So that's all I have for this. Now, I do have another much briefer slide set that talks about some of drugs for other endocrine disorders. So that's coming up next.